I just got back last night from Haiti, and it's wonderful to see how hard people are working, predominantly Haitians are working, to make things better. There are a lot of challenges, but things are going in the right direction. So I'm going to talk a bit about our solidarity with people whose lives we don't know, but whose needs we know well, because they're exactly the same as our own. I want you to hold on to that thought for just a moment, because first we're going to talk about money. A couple months ago in Boston, one of the city's major teaching hospitals launched a $1 billion fundraising campaign. So the money will be used for patient care, for innovation, for new discoveries, all incredibly important and much needed work. At the same time, it caused me to think, wow, $1 billion. $1 billion is a lot of money. And much closer to home, last year, Princess Margaret Hospital here launched a $1 billion fundraising campaign focused on cancer. So the idea is to fund personalized cancer research so that one day soon, doctors will be able to base their treatment on the specific genetic makeup of the patient. So this could be a game changer, and it's incredible this work is being done right here in Toronto. And once again, at the same time, it caused me to think, wow, $1 billion for one hospital is a lot of money. As I might have put it when I was about 10, imagine how many hockey sticks that can buy. And it can buy a lot of hockey sticks. But these examples and a few others, there are other billion-dollar hospital fundraising campaigns going on in North America, have crystallized a question that I've been thinking about concerning the work that I do, a large part of which is fundraising for global health. And so by global health, I don't mean health far away, but rather health wherever there is need for people living in poverty. And some of the greatest needs in the world are in Canada's Aboriginal communities, to our national disgrace. And the needs are also great in places like Haiti or Bangladesh or Nepal or sub-Saharan Africa. So suffice to say, there's a lot of work that needs to be done. So back to the question, and here it is. What would the reaction be if the organization I work for, Partners in Health Canada, announced that we were launching a $1 billion fundraising campaign, not for a hospital, but for global health, for the health of poor people, because health is a human right? So there are about 7 billion people in the world, and about 2.8 billion of them live on less than $2 a day. These are some of the people that we're talking about. And we would use our global health $1 billion to facilitate delivery to these people in their own countries of the same sorts of medical technology and capacity and infrastructure and medicines that we, all of us here, have long taken for granted. In other words, you might say it's for nothing new. So what would the reaction be? Well, it might be, well, geez, $1 billion? Isn't that a little ambitious? Or it might be, well, yeah, it's important, but $1 billion is a lot of money for us to be spending on other people's health. Or it might be, how do I know that money is going to get to the right people and do what you say it's going to do? Because these places are so poor and so chaotic that I'm not really sure it will. So these are all life as we don't know it questions. You know, we don't know the people the Global Health $1 billion will help, who they are, where they live, or how they live. And so when deciding where our dollars can be effective, we tend to draw boundaries around places we know and places we've been, things we trust. And this is only natural. But here's the key point. Wherever we draw the boundaries about what can be effective and where we can be effective, these are artificial boundaries that people choose to make. We often put up the boundaries about what's possible and what's not without even really thinking about it. Because all the incredible advances that have been made in treatments for things that cause sickness or cause death, for example, vaccines or drugs to treat cancer or diabetes or AIDS or tuberculosis, protocols for safe childbirth delivery, C-sections, surgeries, these things don't have boundaries. You take the same patient in Toronto or Tehran or Timbuktu, give her the same treatment, and you'll get the same result. And yet, when it comes to treating people in settings of poverty, when it comes to global health, often we get reactions and we get things like this. So tuberculosis is an infectious disease, typically attacks the lungs. It affects about 1.5 million or kills 1.5 million people every year, almost all of them in developing countries. Multi-drug resistant strains called MDR-TB can be extremely difficult to treat. The regimens are long and hard and complicated. They have painful side effects, and that assumes that the capacity exists to make a proper diagnosis and treatment plan in the first place. But as you can see here, the World Health Organization wasn't saying difficult. Difficult we could understand. It wasn't saying expensive, although we could understand that too, because the drugs were very expensive at the time. No, it was saying often impossible. Impossible. Think about that. So this obviously wasn't intended to be a malicious statement, but words like impossible have policy implications that can affect the lives of hundreds of thousands or millions of people. Would anyone dare say treating MDR-TB was impossible if the patient happened to be living in New York or Geneva or Toronto? So another example. In 2001, AIDS was devastating poor countries worldwide. And this is 6 years after antiretroviral therapy was essentially rolled out in rich parts of the world, effectively making AIDS a treatable disease. And yet here we had a lead official with the United States' top development agency arguing that the response of the international community to the AIDS epidemic in Africa should be to focus only on prevention for reasons that, well, you can see the reasons why he was saying this. Now, prevention is obviously critical. It's very important. But one of the consequences of this prevention versus treatment dichotomy, as if we can only do one or the other, was that it would condemn tens of millions of people living with the disease to die. And this is at a time when we already had the drugs and the know-how to treat them. So this is a picture of a man named Joseph Jeune. Joseph was co-infected with HIV and tuberculosis. He lived in Haiti, not sub-Saharan Africa, but you get the story. And that story being that in 2003, in most developing countries in the world, families knew that if they had a patient who looked like that, or a family member, there wasn't much left to do except buy a coffin. And Joseph's family had, in fact, bought a coffin at the time this picture was taken. So the good news, and there's a lot of good news, is that there are a number of organizations that have tried and continue to try to turn this kind of thinking on its head, to say that it is indeed possible to do the same things in poor countries as are considered routine in rich countries. And I'm proud to say that Partners in Health is one of them. So Partners in Health started treating MDR-TB in Lima, Peru in 1996 using community health workers to help accompany patients through the course of their treatment. And patients were also provided with social supports, things like food or money for transportation, or help with childcare while they were at the clinic. All these things that are often barriers for patients being able to access care or seek care in poor settings, and so are just as important as the clinical treatment itself. At the time when Partners in Health started doing this, the patient load, the number of patients started only about 10, moved up to 50, 75, very small number, in part because the drugs at the time cost between $15,000 and $20,000 per patient. So Partners in Health also started a global lobbying effort to mobilize to drive down the price of those drugs. And between 1997 and 2000, the price of drugs to treat MDR-TB fell by 95%. So the drug prices weren't fixed as so many people thought originally. And so because of the clinical successes and the reduction in the price of drugs, 10 years after the WHO said treatment was often impossible, we got this. Look, Ma, it's not impossible anymore. You know, what a triumph that is. And it's proof that we can change policy by doing the right thing and by not giving up. And so back to Joseph. Partners in Health had also started one of the first programs in the world to deliver antiretroviral therapy to people in rural areas in developing countries in poor settings. And so that picture on the left is Joseph, just 6 months after starting treatment. And on the right, he's on the cover of a 2004 World Health Organization report as proof of what is possible. So Partners in Health co-founder Dr. Paul Farmer says, and I'm quoting here, "We live in an era in which simply seeking to provide high-quality medical care to the world's poorest is considered innovative and entrepreneurial." That's the narrative we need to change. So it's not innovative and entrepreneurial, but rather part of a broad-based movement for global health equity. So we can stop at minimum 10 million deaths every year that are easily preventable. And that's just a bare bones starting point. So what's it going to take? Well, it'll take lots of things. It'll take perseverance and compassion and solidarity, those things for sure. It'll take continued training for doctors and nurses and community health workers. It will take working to strengthen public sector health systems in partnership with communities and national governments. And here are a couple examples of what those partnerships can look like. These are 2 hospitals that were built by Partners in Health over the past 3 years in partnership with communities and ministries of health. On top is Butaro Hospital in northern Rwanda. It's an incredible place. Before that was built, women had to literally row across a lake to access facility-based birth. And so you can imagine how that worked out and how many women died in boats trying to get across the lake. That hospital is also now home to the first rural cancer center of excellence in all of East Africa. And why? Because cancer is a big problem in Rwanda too. On the bottom is University Hospital in Mirabel, Haiti. It's really unbelievable, fully solar powered, has 300 beds, 6 operating theaters, the only CT scan in the public sector in the entire country, electronic medical records, medical residency programs, wastewater treatment. I could go on and on. There's nothing else like it. And sometimes we get asked, why so fancy in such a poor place? Well, the answer is easy, because remember, we know the needs well. They're the same as our own. So for me, meeting these needs or being a very small part of playing a role in meeting these needs is really about social justice. I'm Jewish, and I grew up about an hour from here in Kitchener-Waterloo. It wasn't always the easiest place to grow up being Jewish. There weren't many of us. And I remember in high school, sometimes we'd be playing basketball, and the ball would hit the rim, and the guy that shot it would call the rim a Jew because the ball didn't go in. And I remember also being very young, much younger, and I would see the street signs that said, yield to pedestrians. And in my head, I'd be thinking, those Presbyterians, they get everything. Why is it always the Presbyterians? Where are the yield to Jews signs out there? And I never saw those yield to Jews signs. But I think we all have these kind of stories inside, these personal stories. And I think we all have our limits about what we think is possible and how hard and how long we're willing to push to get there. And so I encourage you to fight those limits with ferocity. The limits that say, for example, that we're just being realistic to think we can only provide limited care in poor places or rural places or places afflicted by hard to treat diseases. Or the limits that say we just don't have the capacity and the ability to do that over there when we're already doing it right here. Or the limits that say, for example, that it's ridiculous to think of a $1 billion fundraising campaign for global health. And so now I'd like to announce that Partners in Health Canada is not going to launch that kind of campaign. Not yet. But our starting point and our objective to provide high-quality, comprehensive care for those living in need and in poverty wherever they live has to be no less ambitious. Because if we truly believe in healthcare and health as a human right, as we say we do in Canada, it's the only thing to strive for. And because we already know it's possible. Thank you.